Hello, future RMTs. Welcome to the discussion of thyroid and parathyroid function. Our learning outcomes are as follows. Number one is to recall the function, biosynthesis, metabolism of thyroid hormones, and interpret laboratory results to determine the abnormalities in the metabolism and synthesis of thyroid hormones. To start with, let us define what is a thyroid hormone. It's nice to know that thyroid hormone is located near the larynx, no, that exerts significant control over the rate of metabolism. Okay, and this organ is divided into two lobes, no, which will be discussed later. Now, we said that thyroid hormones or thyroid glands is responsible for the production of thyroid hormones, which are all important in the metabolism of the rate of metabolism in humans, and of course for neurological development. Okay, aside from thyroid hormones, thyroid gland is also capable of secreting our calcitonin, which is important in our calcium homeostasis. So thyroid hormones produced by our thyroid gland are T3, T4, and calcitonin. T3 is also known as the triiodothyronine and T4 is also known as the thyroxine. Okay? Now, like what I've said, our thyroid gland is located or positioned in the neck and has a butterfly shape. No? And it is made of two lobes that rest on each side of the trachea. There is also what we call isthmus. No? Okay? Isthmus of the thyroid, which serves as the bridge, no, of the lobes, no, that covers the trachea. This is also known as the band of thyroid tissue running anterior to the trachea. Okay? These are the two hormones produced by our thyroid gland, T3 and T4. Now remember guys that the thyroid hormones stimulates the metabolism throughout the body, no? And their major effect seems to be increased consumption of oxygen, probably through hormone involvement with mitochondria. Now, take note also that the most metabolic processes involving the utilization of materials appear to be enhanced by our thyroid hormone, including carbohydrate metabolism as well as lipid utilization. That's why if you have a problem with your thyroid gland or thyroid hormone, you will also develop a problem in your glucose metabolism as well as your lipid metabolism. Remember guys that the nature of our thyroid hormone no receptor interaction is with DNA and we expect that protein synthesis will be stimulated. Now, aside from thyroid gland, there are four or up to eight tiny organs or tiny glands, which is also an endocrine gland that is situated posteriorly to our thyroid gland. And these are what we call no? And these are what we call the parathyroid gland, no? The parathyroid gland is responsible for the regulation of serum calcium homeostasis and it is responsible no for the secretion of the parathyroid hormone. Now remember guys that parathyroids are embedded in the tissue of our thyroid gland. That's why if there is a surgical removal of our thyroid gland, there is also a removal of the parathyroid glands because you cannot, no, you cannot retain the parathyroid glands within the thyroid because it is situated posteriorly to our thyroid glands. Now, remember guys that the injury in the parathyroid gland can lead into hypocalcemia, which is decreased level of our calcium. No? Parathyroid hormones and parathyroid gland is responsible in what we call calcium homeostasis. Moving forward, we said that in terms of anatomy and development, no, on during the 11th week of gestation, the thyroid gland begins to produce measurable amounts of thyroid hormone. Okay, and the thyroid hormone is critical for the neurologic development of fetus during the gestation. Remember guys that iodine is also an important element no, and an essential component of the thyroid hormone. If you still remember, no, we have your triiodothyronine, meaning to say in the thyroxine or in the tyrosine rather, in the tyrosine as the parent, no, amino acid of our thyroid hormones, no, that is the amino acid where our iodine will attach. Take note, guys, that iodine is important in the production of our thyroid hormone. So later, we're going to discuss that. Now, remember, guys, that iodine, no, can be found in seafoods, okay, the dairy products, iodine-rich breads, and vitamins. And the recommended intake of our iodine is 150 micrograms, okay, 150 micrograms per day. We also have what we call the hypothyroidism. Hypothyroidism is a condition which can lead into mental retardation and creatism. A creatism, when you said creatism, okay, this is a condition, right? This is a condition characterized by physical deformity and learning disabilities that is caused by congenital thyroid deficiency. Yan. A baby, no, with congenital hypothyroidism will look like this. Now remember, guys, that in congenital hypothyroidism, it means that after the birth, or after birth, meron ng problem in the thyroid gland ang ating baby. Bakit? Ano meron congenital hypothyroidism? Now remember that during the 11th week of gestation, that is the time wherein the baby were able to what you call this, produce detectable amounts of thyroid hormones. Now, and thyroid hormones is responsible for the neurological development. That's why if there is a, no, deficiency of thyroid hormones, naglilid ito into what we call the mental retardation. Now, what happened in congenital hypothyroidism? In congenital hypothyroidism, the baby, or the fetus in the mother's womb becomes dependent on that mother's thyroid gland or thyroid hormone production. That's why there is a failure, no, of the thyroid to fully develop. Now remember, guys, that a baby, no, with congenital hypothyroidism is characterized by lethargy, weakness, failure to develop, no, and lead again to mental retardation. Okay? So this is what I've shown you before. This is what we call the synthesis of our thyroid hormone. Now remember, guys, that our pituitary gland, no, is the one responsible of secreting our TSH. No, so pituitary gland responsible for secreting our TSH, which will stimulate the follicular cells, okay, which will stimulate the follicular cells of the thyroid gland. No, and these follicular cells of the thyroid gland will be the one, no, responsible for the production of our T3 and T4. And since T3 and T4 are thyroid hormones, is responsible for metabolism, its target tissue is the liver, no, for the metabolism. Now remember, once that there is already the production of T3 and T4, no, it will give signal to our pituitary and even to our hypothalamus to stop the production of TRH, which is your releasing factor that will give signal to TSH, anterior pituitary gland, no, to produce the TSH. Remember, guys, that this process of thyroid hormone synthesis again begins at the hypothalamus, where TRH, or also known as our thyrotrophin releasing hormone, no? Where our thyrotropin releasing hormone is produced. Now, once that the TRH is produced, okay, once that the TRH is produced, okay, this peptide is released in response to specific stimuli. Bakit nagkameron? Okay, uh, let me just erase this first. Sige. Bakit nagkameron ng production of TRH? Okay, TRH, the production of TRH becomes possible. It is because of the stimulus. Okay? And one of those stimulus includes the decreased levels of our thyroid hormones. Decreased level of thyroid hormones is one of the reasons why TRH was secreted by our hypothalamus. Then what will happen? Okay, TRH, our thyrotrophin, let me write it, Thy, thyro, thyrotropin. Okay, thyrotropin releasing hormone, okay, acts on the pituitary, particularly on the anterior pituitary gland, okay, particularly in the anterior pituitary gland, causing the synthesis of what we call TSH. Causing the synthesis of what we call TSH, also known as our thyroid stimulating hormone. Now, the thyroid gland interact with the TSH. Okay, so the TSH will act, since this is a stimulating hormone, a signal, chemical signal to the thyroid gland. It will act, no, into our thyroid gland. The TSH will act into our thyroid gland, particularly in the follicular cells. Okay, particularly in the follicular cells. Now, what will happen? Okay, this will initiate the production or the process of what we call thyroid hormone synthesis, wherein T3 and T4 will be released. Okay? Now, remember guys that T3 and T4 as amino acid hormone requires carrier protein. The T3, the triiodothyronine, tyronine, and the thyroxine will bind to its will bind to its carrier protein. At sino yung mga carrier protein ng T3 at ng T4 natin? The major carrier protein, take note ha, that the major carrier protein of our T3 and of our T4 is our TBG. Okay? TBG. TBG stands for thyroxine binding globulin. Okay? Thyroxine binding globulin. Now, aside from thyroxine binding globulin, our T3 and our T4 will also bind to our another TPB naman, TBP, thyroxine binding pre-albumin. Okay? Again, remember that our T3 and our T4 are both requiring carrier proteins. They will be bound to TBG, thyroxine binding globulin, or thyroxine binding prealbumin. Okay? In the circulation for what? For transport to the target tissues. The target tissue, again ha, makinig, the target tissue of our thyroid gland, of our thyroid hormone rather, is our liver, no? And aside from liver, the target gland of or the target organ or the target tissue of our T3 and T4 aside from liver is the hypothalamus and our anterior pituitary gland. Why? Bakit si anterior pituitary gland at saka si hypothalamus ay magiging target tissue din ng ating T3 and T4? Because the thyroid hormone synthesis, no, shows a negative feedback mechanism. Okay? Shows negative feedback mechanism. Now, the process will repeat. The process will repeat if there is a deficiency again in our thyroid hormone production or the level of our thyroid hormone. So that's basically how the thyroid hormone is being synthesized. Okay, on the next slide, we're going to discuss in the thyroid follicular cells, paano na-synthesize further? Ano yung reactions na nangyayari? But before that, no, let's discuss first our TRH. Okay, remember guys, that TRH is a small peptide. Okay, TRH is a small peptide composed of three amino acids. Composed of three, let me just delete uh, my annotations. Okay. So again, TRH, okay, excuse me. TRH is a peptide composed of three amino acids, and these molecules is synthesized primarily by the hypothalamus. TRH appears to be effective, no, in to trigger, no, for the release of what you call this, TSH, and aside from that of prolactin. Okay, so si TSH at saka si prolactin ang na tini-trigger ni TRH. So si TSH naman, the thyroid stimulating hormone, on the other hand, no, uh, is a product of our anterior pituitary gland with an interaction or with the interaction with our TRH. Okay? There are two subunits of our TSH, the alpha and the beta subunits. The alpha subunits has the same structure as of our luteinizing hormone, LH, FSH, or follicle stimulating hormone. O, sulat natin para hindi nyo malimutan. LH, FSH, and TSH. Ayan na nga, si TSH. Ayan yon. Okay? LH, FSH, TSH, at saka si gonadotrophic, chorionic gonadotrophin, no? And our beta naman, no? Our beta pala is for our HCG rather. Yan. Our beta is for our HCG, which is for pregnancy. No, aside from pregnancy, we can also use the beta HCG for as tumor markers. Okay, remember guys that the TSH now interacts with the receptors on the cell membrane of the cells in the thyroid gland, particularly in the follicular cells. And it will trigger the release of our triiodothyronine and of our thyroxine, which is our T3 and T4. Now, like what I've said, let's discuss how TSH triggers or stimulates, that's the right term, how TSH stimulates the formation or the production of our T3 and of our T4. Okay? Listen very well. Remember guys that the formation of thyroid hormone is a complex process. Medyo magulo, no? Because why? It involves protein synthesis and iodine take-up. Like what I've said, iodine is important. I remember that the thyroid hormone synthesis in the follicular cells or in the follicular epithelial cells of the thyroid is a complex process because it involves protein synthesis and iodine take-up. Aside from that, there is what we call incorporation, intramolecular arrangement, protein hydrolysis, and release of the hormones into the circulation. Now, remember that the thyroglobulin, okay? Remember that the thyroglobulin is synthesized in the initial stages of this process. Ayan. Remember guys that the thyroglobulin is synthesized in the initial stages of this process. Remember that thyroglobulin is a protein. Okay? This is a protein. Okay? This protein is a large molecule. No? This protein has a or is a large molecular weight material. Okay? Approximately 2% of amino acids in the thyroglobulin are tyrosine. Okay? Approximately 2% of the amino acids, kasi nga 'di ba, a protein na meron siyang amino acids, 2% of it is 10%, I'm sorry, 2% of the amino acids, okay? 2%, no, para maliwanag. 2% of the amino acids, 2% of the amino acids in the thyroglobulin is what we call our tyrosine. Okay? Tyrosine. Sabi natin, si tyrosine is important amino acid in the synthesis of our thyroid hormones. Why? Because this is considered or that is considered as the backbone of the thyroid hormone molecule. Furthermore, no, to continue the production of this uh, thyroid hormones, so yung thyroglobulin, no, nagkaroon na ng synthesis. Now what will happen? There will be what we call incorporation of our iodine to form tyrosines, no? There will be a incorporation of our iodine to form our iodotyrosine. Okay? Why? Bakit nagkaroon ng incorporation of iodine? Take note that iodine, no, that iodine from the from the bloodstream plays an important role in the structure and functions of our thyroid hormones. I repeat, iodine plays an important role in the structure and function of our thyroid hormone. Since the only difference between T3 and T4 is the number of iodine that is attached into the tyrosine. Okay? The iodine form from the iodine, no, from the diet, okay, undergoes a complex of series of reaction before being incorporated into our thyroid hormone synthesis. That's why we have here our iodine active transport. Okay? Ano po yung mangyayari? The anion is being filtered, okay, from the plasma and concentration in the section of the thyroid glands. Then it undergoes what we call activation reaction. Okay? However, the process of undergoing the activation reaction of our iodine still not yet clear. Now, remember that before, no, remember that before the iodine becomes a part of the tyrosine ring, either one or either tama, either one, you know, either one or two, no, either one or two molecules can react or can bind with our tyrosine. Okay? The tyrosine as the amino acid, no, the major amino acid in the thyroglobulin will have an incorporation with our iodine, producing our iodotyrosinase. Now remember that the iodotyrosinase can be your monoiodotyrosinase or your diiodotyrosinase. Tyrosines pala, hindi tinase, naging enzyme, sorry. I repeat, to make it clear, one or two of the iodine will bind to tyrosine, producing our iodotyrosines. Iodotyrosines. Okay? And these iodotyrosines, ito natin nilagay, iodotyrosines can be monoiodotyrosine and diiodotyrosine, depending on the number of, no, depending on the number of iodine that attaches to our tyrosine amino acid. Now, what will happen? After the iodine, no, after the iodine is incorporated in the tyrosine ring, two, makinig, two iodinated tyrosines undergo what we call coupling reaction. Okay? After, okay? After, no, that the iodine is incorporated, ito na yan, yung MIT natin at saka yung mga DIT natin. After that, what will happen, these iodinated tyrosines will undergo what we call coupling, okay, of MIT and DIT by thyroid peroxidases. Okay? By thyroid peroxidases. The combination, makinig ha, the combination of monoiodotyrosine and one iodotyrosine forms our triiodothionine. Ulitin natin. Barahin natin ito. Okay. So after, medyo habaan ko lang itong aking whiteboard at hindi ko masulatan ng husay for a while. Yan. So para tayo nagkakasulatan ng husay. Now remember guys, after the iodine is incorporated in the tyrosine ring, it will produce our iodinated tyrosines. So ito po yung sinasabi nating iodinated tyrosines. Ang isa dyan, si monoiodotyrosine at yung isa is si diiodotyrosine. Now what will happen? The combination, there will be combination of MIT and DIT. Okay? Combination of one MIT and hihirapan mo sila. One MIT and one DIT will give us 3, 5, 3 triiodothyronine. No, this is one word lang. 3, 5, 3 triiodothyronine, which means this is now your T3. Okay? This is now your T3. Ito yung nangyayari sa atin. Okay? One MIT and one DIT will give you your 353 triiodothyronine T3. This is the IUPAC name. All right. Next, if there are two, if there are two diiodotyrosine groups produced as one molecule rather, it will give us your T4. And that is your uh, 35, ano no, 335, okay? 335, mm, no, no, no. That is your 3535, okay? Tetraayodo, tyronine, which is your T4, okay? Tetra, 4 iodine, T4. T3, tatlong iodine. And this is commonly referred as your thyroxine, okay? T4 is our thyroxine. Okay, now what will happen? The enzymatic hydrolysis, take note, huh? The enzymatic hydrolysis of thyroglobulin, no, that is still within the cells of the thyroid gland, releases our T3 and our T4 into the circulation, no? And a small amount but measurable amounts of thyroglobulin also enters into the bloodstream. Remember, small amounts but measurable amount. No, small but measurable amounts of thyroglobulin will enter into our bloodstream. The purpose of having our thyroglobulin into the bloodstream is that it is an indication that our thyroid gland is functioning. Okay? So that is how our thyroid hormones is being produced. Okay? So that is how our thyroid hormones is being produced. Again, ulitin natin. The thyroglobulin, which is important protein, no, in the synthesis of our thyroid hormone, acts in incorporation of iodine to form our iodotyrosinase. Since, okay, the iodine from the bloodstream, no, the iodine from the bloodstream will get entry or will gain entry into our thyroglobulin, into our follicular cells through iodine active transport mechanism. It will give us it will give us mono iodotyrosines and diiodotyrosines. And the coupling of this MIT and DIT is happen because of the thyroid peroxidase, which then will give us the process of thyroglobulin endocytosis. One MIT and one DIT molecule will bind to each other, forming your 353 triiodotyrosine, which is your T3. Or if there is what we call combination of 2DIT, it will give us our 3535 tetraiodotyrosine, which is now our T4. Therefore, this uh, reaction through the enzymatic hydrolysis of thyroglobulin will allow the T3 and T4 to release into the circulation. Along with that, a small amounts of thyroglobulin is being produced, and the function of that is to know that there is what we call uh, active active mechanism or active pa ang ating thyroid hormones, thyroid glands rather. Now, like what I've said, our thyroid hormones requires carrier protein, tama? It requires carrier protein. Sino nga yung mga carrier proteins natin? Si thyroxine binding globulin, TBG, our thyroxine binding prealbumin, TBPA, and also our serum albumin. Having said that these are the three binding proteins, it is nice to know that the major uh, carrier protein is no other than our TBG. No? Majority of our hormones are attached to TBG, lesser amounts to other carrier proteins. Now, remember guys that the binding of T4 is essentially complete with only 0.03 to 0.05, or in other books it says 0.04, ay an average of 0.04 in our bishop, no, ang sabi diyan 0.04. And then the attachment of T3 is somewhat weaker, which is approximately 0.4, okay, of the T3 circulates unbound. Now remember guys that once in the circulation, these hormones can interact with cells, no, with cell membrane to produce the appropriate biochemical reaction. Okay, remember also that both T3 and T4 undergoes metabolic inactivation in the liver where iodine atoms are removed to be recycled for further thyroid hormone synthesis. And that is what we call the metabolism of our thyroxine. Okay? In the metabolism of our thyroxine, there is what we call monoiodinase. This enzyme will remove one, no? This enzyme will remove one iodine, no? In our T4, giving us the inactivated T3 or the RT3 and our active thyroid hormone T3. Again, no? Both T3 and T4 undergo metabolic inactivation, most especially our thyroxine. There is what we call in metabolism of thyroxine, wherein monoiodinase, an enzyme, will remove one, no? Will remove one iodine to our T4 so that it will form as active thyroid hormone, which is your 353, no? 353 triiodothyronine, which is our T3, and the other one is the inactivated thyroid hormone, which is the 335 triiodothyronine. Okay? This happens in our liver. Now, remember that little amounts of thyroid hormones can be excreted in our urine, no? Can be excreted in our urine. So this is what I am telling a while ago. Our carrier proteins, no? Your TBG, your TBPA, and our albumin. Ayan, 0.04 of T4, no? 0.04 of T4. Ang range nito ay 0.03 to 0.05% of T4, an average of 0.04, and 0.4 of our T3 circulates unbound. Again, remember guys that the thyroxine binding globulin is our major transport protein, no? Uh, and this material is a low molecular weight protein that is synthesized by our liver. Okay, and then what are the actions of our thyroid hormones? Okay. Actions of the thyroid hormones includes the T4 is deiodinated into T3, no, giving us the active form. And once released by the thyroid gland, thyroid hormone circulates into the bloodstream. And in the cytoplasm, T4 is being deiodinated into T3 to the active form. Therefore, the T3 combines with the nuclear receptors on the thyroid hormone responsive genes, leading to the production of what we call messenger RNA that leads to the production of proteins that influences metabolism and development. Now, there are major five effects of our thyroid hormone aside from the metabolism, and those are for tissue growth, brain maturation, increased production of heat, increased oxygen consumption, and increase in beta adrenergic receptors. Now, aside from that, no, there is also what we call thyrotoxicosis. When we said thyrotoxicosis, there is an excessive production of our thyroid hormone. And thyrotoxicosis is incorporated with increased metabolism, no? Which can leads into tachycardia, okay? Which can leads into tachycardia. When you said tachycardia, it is an abnormally fast heart rate beyond 1,100 beats per minute in a resting state. No, wala lang. Wala akong masyadong ginagawa. Pero yung iyong uh, heart rate is greater than 100. Okay? Aside from that, thyrotoxicosis can also lead into tremors. Kaya yung may mga hyperthyroidism, nanginginig sila eh. No? Nanginginig sila. And then, sila yung mga payat. Bakit? Mataas yung kanilang thyroid hormone. Mabilis ang kanilang metabolism. On the other hand, we have your hypothyroidism, which means there is an inadequate thyroid hormone production. Now, there are available tests for the evaluation of our thyroid hormones, which includes the blood test, no, the nuclear medicine evaluation, thyroid ultrasound, and fine needle biopsy. Okay? So TSH, take note, is the most useful test for assessing the thyroid function. Sir, TSH is not a hormone produced by our thyroid glands. How come the TSH is one of the most useful, no, most useful tests for assessing the function of thyroid gland? Again, if we are going to define, no, the function of our TSH, we said that TSH, no, is the one that stimulates our thyroid hormone. Therefore, if there is a deficiency in our thyroid hormone, there might be a deficiency also or a problem in the production of our TSH. That's why it is important or nice to measure the TSH. Remember guys that uh, TSH levels has been shown to be extremely useful in the diagnosis of the thyroid disorders. Okay, where TSH values are usually elevated. Bakit? If there is a problem in the production of thyroid hormones, baka kasi in cases of hypothyroidism, if there is a deficiency in hypothyroidism, it means that there is a problem in the thyroid gland itself. Aside from that, it can also be a problem in the anterior pituitary gland, the problem in the TSH. Kung si anterior pituitary gland is not capable of producing TSH, therefore our thyroid hormone or thyroid gland will also have a deficiency in the production of our thyroid hormones. Now remember guys that the TSH can be assayed through three generations. The first generation assay, the second generation assay, and the third generation assay. Now remember guys that the second generation assay can be done through immunometric assay, which the detection limits is 0.1 milliunits per liter, and that is effective for screening hypothyroidism. On the other hand, the third generation assay naman is chemiluminometric, no? Chemiluminometric. Okay, and the sensitivity of this one is 0.01 milliunits per liter. So, ibig sabihin, mas sensitive to. Bakit? Mas mababang amount kaya niyang i-detect as compared to the second generation. Now, remember that TSH can also be assayed through our RIA or immunoradiometric assay and IRMA. No, no, no. Uh, ang IRMA yung ang RIA is radio immunoassay. I'm sorry. Radio immunoassay and IRMA na stands hindi si IRMA na girlfriend ni Mr. Win ha. IRMA stands for uh, immunoradiometric assay. Yan, IS. Remember guys that the TSH can be uh, measured, no, using these two immunological assays, RIA, radioimmunoassay, or IRMA, immunoradiometric assay. No? And remember that the IRMA method, take note that the IRMA method has the advantage of giving uh, direct responses in the assay. Therefore, the amount of bound to antibody is directly proportional to the quantity of our TSH present. Okay? The third generation, additional information for the third generation. The third generation is capable of distinguishing the euthyroid and hyperthyroidism. When you said euthyroid, now this is a condition in which the serum levels of the thyroid hormones are low in clinical patients with non-thyroxidal systemic illness. Okay, and this is also sensitive, no, in the detection of subclinical hypothyroidism. Now, ano yung ibig sabihin ng subclinical hypothyroidism? When we said subclinical hypothyroidism, it means that the TSH is minimally increased while the T4 or the FT4 in particular is normal. On the other hand, we also have what we call subclinical hyperthyroidism, wherein TSH is suppressed while the FT4 is normal. So we have here a summary of the conditions wherein the TSH is low, the TSH is high, the FT4 is low, the FT4 is normal, the FT4 is normal. Okay, so this is just a summary. It's for you to find it out. Aside from that, we have the serum T3 and the T4. No, mahalaga to. Why? These are all important because aside from the TSH, it is also important to measure our thyroxine and triiodothyronine. Bakit? Because these are the uh, hormones being produced. Okay? And usually, this can be no, this can be measured through what we call radioimmunoassay or chemiluminemetric assay. Now, what we have here, remember guys that the wide variety of immunoassays methods or immunoassay methods that are available, no, is capable of measuring the T3 and the T4. Now, RIA, no, RIA or radioimmunoassay still appears to be the most prevalent approach. Okay, why? Because enzyme immunoassays of several types and fluoro immunoassays are gaining popularity, and for that reason, no, RIA becomes common. Now, what will happen? Take note of this. I have here a diagram. I want you to listen well as I discuss this diagram. As you can see, we have there what we call T4 TBG complex. Okay, we have there your T4 TBG complex. Now, ano po yung meron dito? The separation of this step is still required. No? The separation of the TBG and the T4 complex is required, and that is what we call the dissociation step. Okay? we're in the T4 will be removed from the TBG. Complex sila eh. So ibig sabihin that the T4 is being bind or meron siyang binding sa ating TBG. It will be removed. Therefore, what will happen? Okay? What will happen is that uh, in the separation step, no, the TBG will be discarded, and then we will be able to measure our T4 using the immunoassays. Now remember that serum is the most commonly used sample for T4 analysis or preferred sample for T4 analysis or in most thyroid analysis. Okay? Take note that the thyroxine in the serum remains stable for several days. Although storage at low temperature is recommended. So sometimes we freeze the sample. Remember that hemolysis, yan. Remember that hemolysis and lipemia, okay? Hemolysis and lipemia, no, will not create a problem. Usually, there's no a problem. Ibig sabihin, kung lipemic at saka hemolyzed yung sample, edi okay lang. Wala namang masyadong problema. Okay? Walang masyadong problema. Now, how about thyroglobulin? Thyroglobulin, like what I've said a while ago, this is an important protein synthesized by the liver. Okay? And uh, secreted exclusively by the thyroid follicular cells. This is what we call prohormone. No? This is what we call prohormone. Ano bang ibig sabihin kapag sinabi nating prohormone? When we said prohormone, these are peptide hormones that initially secreted as a hormone, no? Which do not exert any biochemical activities of their own. Okay? So that is prohormone. Okay? And this prohormone is a proof that the presence of thyroid tissue is still active. Aside from thyroglobulin, we also have your thyroid autoimmunity. No? These are antibodies, no? Directed at the thyroid tissues with the variable responses. Now, there is what we call Graves' disease. Hindi Graves, ha? Graves' disease. Graves' disease is most common cause of hyperthyroidism, which is a autoimmune disorder. Wherein the antibodies, wherein the antibodies, okay, is directed to TSH receptors that stimulates the receptor, leading to the growth of thyroid gland, and production of thyroid hormone is excessive. Again, I repeat, Graves' disease is an example of or the most common cause of hyperthyroidism, and Graves' disease is an autoimmune disorder. Having said that this is an example of an autoimmune disorder, okay, there is the antibody, no? The antibody in this condition is directed to the TSH receptor, thus it will lead into the stimulate, no? It will stimulate the receptors leading to the growth of our thyroid gland and to excessive production of our thyroid hormones. That's why there is what we call hyperthyroidism. On the other hand, we also have what we call chronic lymphocytic thyroiditis, which is a classic sign of Hashimoto's thyroiditis. If Graves' disease is a condition wherein there is an excessive production of our thyroid hormones, Hashimoto's thyroiditis, on the other hand, is naman cause of hypothyroidism. In Hashimoto's thyroiditis, where there is a patient, no, the antibodies of the patient leads to decreased thyroid hormone production by thyroid gland, and Hashimoto's thyroiditis is best assayed or best tested or detected using TPO. What is TPO? Thyroid peroxidase. Okay? Hashimoto's disease or Hashimoto's thyroiditis is a cause of hypothyroidism wherein the antibodies lead to the decreased thyroid hormone production by thyroid gland. And that is the best test for Hashimoto's thyroiditis is no other than our TPO or thyroid peroxidase. Now, aside from blood tests, there are also other tests such as nuclear medicine evaluation. In nuclear medicine evaluation, the patient is given ng radioactive iodine which such as the iodine 125. Take note, the radioactive iodine 125 is useful in assessing the metabolic activity of the thyroid tissue and assisting in the evaluation and treatment of thyroid cancer. Radioactive iodine, such as iodine 125, is given orally, and there is what we call RAU. RIU. What is RIU? RIU stands for radioactive iodine uptake. In this reason, no, kapag yung RIU natin is high, if the RIU is high, it means that the gland is active. Gland is and active and capable of producing hormones. Now, if the RIU is low, it means that the thyroid hormone or the thyroid gland is metabolically inactive. Take note also that radioactive iodine is also important in detecting thyroid nodules. When you said thyroid nodules, there is a take up uh, take up significant radioactive iodine on the thyroid scan, like this. Okay, and if there is a hot nodules as detected by the nuclear medicine, hot nodules means unlikely thyroid cancer, while okay, cold nodule means that is cancerous. Okay. However, most of the excuse me, most of the nodules are benign. No? Thyroid ultrasound is used to assess the thyroid anatomy, and if there is a palpable thyroid abnormalities, no, it is also capable of detecting thyroid nodules. And aside from that, we also have your fine needle aspirate biopsy or FNAB, which is the most accurate tool in the evaluation of thyroid nodules. And these are uh, reported according to 6 categories such as non-diagnostic malignant, suspicious for malignancy, intermediate or suspicious for neoplasm, follicular lesions of undetermined significance, and benign. Okay? Here are our reference ranges for our thyroid hormones. But I want to make it clear. No? We cannot standardize a normal range for thyroid hormones or for even any other hormones. Why? Because of the sensitivity and the specificity of the immunological assays being used. But for the purpose of this discussion, these are our reference ranges. So let's proceed to the diseases associated to the problem in our thyroid hormone. First things first is we have our hypothyroidism. Hypothyroidism is characterized with low FT4 but with normal or high TSH. Okay? Remember guys that hypothyroidism is one of the most common disorders of the thyroid gland. This disorder is caused by low production of the thyroid hormone and can be classified as congenital or acquired. So pag congenital, kasi nga yung baby naging dependent lang kay mommy kaya hindi na-develop ng husay ang kanyang thyroid gland which leads into the insufficiency or decrease synthesis of the thyroid hormones. Okay? Uh, Usually, kapag sinabi natin congenital, again, congenital thyroid defect, there is a failure of the thyroid gland to fully develop during the pregnancy. No, that's why it leads into the insufficient hormone production. Okay, and then after birth, ano yung mangyayari kay baby? Meron siyang tinatawag na state of hypothyroidism that is needed to be evaluated every 3 months. On the other hand, no, on the other hand, so sulat nga natin para hindi na tayo dito. Number one can be congenital, or number two, we have your acquired. Ano naman yung meron sa acquired? Acquired hypothyroidism in a patient is usually due to the development of autoantibodies, like what we have discussed in Hashimoto's thyroiditis. Okay? Hypothyroidism can be due to, or hypothyroidism can be classified as primary, secondary, and tertiary hypothyroidism. Kapag po primary hypothyroidism, the problem in the primary hypothyroidism is the thyroid gland itself. Meaning to say that there is an enough TSH, increase to normal levels of TSH, and decreased levels of our T3 and of our T4. In secondary, no, the laboratory findings of secondary and tertiary hypothyroidism is somehow synonymous. Why? Because in secondary hypothyroidism, our TSH is deficit because of the problem in our in our pituitary gland. Okay? Because the problem in secondary hypothyroidism is our pituitary gland. So the TSH is decreased. Definitely, our T3 and our T4 is also decreased. Now, sir, you said that tertiary hypothyroidism is somehow synonymous, no? The laboratory findings of tertiary hypothyroidism is somehow synonymous with secondary hypothyroidism. Why? Because there is also decrease in the level of our TSH, and there is also decrease in the level of our T3 and then of our T4. O di ba parehas lang? Opo. Ano po bakit po? Paano po natin malalaman? How can we know the tertiary hypothyroidism, and how can we differentiate secondary hypothyroidism from tertiary hypothyroidism? We cannot use TSH and T3 as well as T4 as our marker in differentiating our T3 and our T4. In differentiating our tertiary and secondary hypothyroidism. Again, your problem in primary is the pituitary gland, the thyroid gland itself. No, the problem in primary hypothyroidism is the uh, thyroid gland itself. The problem in secondary is the pituitary. That's why we have what we call hypopituitarism. And the problem in the tertiary hypothyroidism is our hypothalamus having said that there is what we call hypothalamic dysfunction. So ngayon nga sir, ang sabi mo nga, how can we differentiate? Eh di mag-measure tayo ng TRH. Bakit? If TRH is deficit, no, if our tertiary hypothyroid, if our hypothalamus is not capable of secreting TRH, kahit okay ang ating secondary, kahit okay ang ating pituitary, at okay ang ating thyroid gland, wala tayong mapoproduce kasi ito yung nag-trigger kay pituitary at saka kay thyroid gland. So, kapag meron tayong primary hypothyroidism, ano yung problema natin dito? There are thyroxidase or thyroid peroxidase antibodies or TGPA, which is your thyroglobulin antibodies, is positive in 80 to 99%. That is in chronic lymphocytic thyroiditis or Hashimoto's disease. Now, treatment for toxic goiter. Ito yung problema minsan. Okay? Yung toxic goiter, meron ka ditong excessive production of our thyroid hormones. Kaya mataas. Ano yung gagawin? Dahil mataas yan, so i-remove natin yung ating mga goiter kasi toxic goiter eh. No? The patient will undergo what we call thyroidectomy or radioactive isotope or radioactive iodine replacement so that there will be an increase in the production of our iodine, of our thyroid hormones. Kaso ano yung problema? The problem on that is it can lead, no, yung hyperthyroidism, if you treat hyperthyroidism, it can lead into what we call hypothyroidism. Excessive iodine intake can also lead into primary problem, no? History and urine iodine measurement is useful. Yung mga subacute thyroiditis, no? Ito yung sinasabi ko, yung mga subacute thyroiditis, yung matataas yung ating mga thyroid hormones, ginagamot tayo eh. We're given drugs, no? So that there will be a normal homeostasis or normal yung level ng ating T3 at T4. Kaso ano minsan nangyayari, nagkakameron tayo ng side effect and the side effect on that is a problem in the production of our thyroid hormones leading into the deficiency of thyroid hormones. Usually naman, no, transient lamang po ito. Now remember guys that hypothyroidism can lead into the variety of abnormalities. Hyponatremia, no, that occur due to inappropriate antidiuretic hormone. Myopathy, no problem in the heart and elevated CK levels. Anemia is a result of decreased demand for oxygen. Kasi sabi natin kanina, ini-increase na yung consumption ng oxygen. So, kapag ikaw ay merong hypothyroidism, may problema ka saan? Okay? May problema ka sa oxygen content natin. Having said that you have a problem in the oxygen, therefore it has or it can lead into pernicious anemia. Okay? So here are the signs and symptoms of hypothyroidism. Signs: delayed relaxation phase of tendon reflex, nanginginig, bradycardia, no? Mabagal yung tibok or mababa yung heart rate, okay? Diastolic hypertension, yellowing of the skin, which is what we call carotenemia, preorbital edema, no, thinning of the eyebrows, of lateral aspects of the brows, no, slowed movement, speech, pleural, pericardial effusions, and even ascites. Bakit? Naglilid niya sa edema eh. Tandaan nyo guys, naglilid sa edema ang ating hypothyroidism because of what? The problem in our ADH. Next, symptoms: cold intolerance, depression, mental retardation for infants, slowed cognition, no, for infants. Menorrhagia, growth failure, pubertal delay, dry skin, edema, yan, no, yan, edema nandyan. Constipation, hoarseness of the voice, and dyspnea on exertion. Okay, so we have again, ito naman, nasabi na natin, just a review. Hashimoto's thyroiditis is an autoimmune disorder, and there is what we call enlarged gland of the thyroid or what we call goiter. Congenital hypothyroidism, again, is a failure of the thyroid gland to fully develop. Now, what is the drug for this? Now, the drug for this is thyroid hormone replacement and levothyroxine. No? Levothyroxine. Now, ano yung common laboratory values sa patient with hypothyroidism? So take note guys that the total T4, bakit ang layo ko naman ng sulat? The total T4 is decrease. Okay? The FT4 is decrease. Okay? T3 is decrease. T3 uptake is decrease. Okay? TBG, the thyroid globulin, thyroid binding globulin is normal. TSH is normal to increase. Okay? Normal to increase. Now, how about hyperthyroidism? We are almost done. No, kapit lang. When you said hyperthyroidism, naman, this is a condition no, wherein the antibody reaction which stimulates our thyroid hormones, no? Our thyroid hormones. Now, the major cause of increased hyper or increased thyroid output is what we call hyperthyroidism. A patient with hyperthyroidism experience weight loss, sleepiness, fatigue, sweating, sense of warmth, increased cardiac output, wherein both T4 and T3 are elevated. Now, remember guys, no, the antibodies, ito yung magandang tandaan dito, yung antibodies natin, siya yung nag-stimulate for the excessive production of the hormones. Okay? And remember, both T3 and T4 are elevated. Now, treatment involves the use of medications to decrease our thyroid hormones. Okay? Or sometimes, surgical removal of the thyroid hormone is recommended. Kasi ano yung problema natin? The problem if there will be a thyroid removal, no, there will also be a problem in our parathyroid hormone that can lead into the problem into calcium homeostasis. Okay? Now, the results or the most common laboratory results of a patient with hyperthyroidism is definitely the opposite of hypothyroidism, wherein total T4, FT4, direct T3, and T3 uptake are all increased. Wherein TBG, since yung ating hormone mataas, yung binding protein natin will also be problematic. Okay? Ano yung nangyayari dito? Our TBG is decreased. Now, TSH naman is low, okay, or undetectable. Bakit? Because of the antibodies, receptors to the antibodies. Okay? Low or normal or sometimes undetectable. We also have what we call thyrotoxicosis, which is wherein the peripheral tissues are presented with and respond to an excess of the thyroid hormone. No? Excessive thyroid hormone ingestion, uh, leakage of that stored thyroid hormone from the thyroid follicles. Now, what are the possible? That is the possible causes. No? And excessive thyroid gland production of thyroid hormones. Okay? So these are the possible causes why a patient develop thyrotoxicosis. Now remember that in thyrotoxicosis, TSH is low, however, FT4 is increased. These are the signs and symptoms associated to thyrotoxicosis. Now, there is a tachycardia, nervousness, irritability, and anxiety, palpitations, no? Weight loss, heat intolerance. Okay? And there is what we call the prominence of the eyes. Yan. We have our Graves' disease. That's the most common of thyrotoxicosis, wherein this is an autoimmune disease. Di ba? Nakakatakot tingnan yung mata. Kung ano, kaya pag ganun. Lagay ko kaya yan sa prelim exam, no? Habang nagsasagot kayo, may mga picture na ganun. Okay? Uh, Again, this is a autoimmune disease in which antibodies are produced that activates the TSH receptor. No? Lab testing shows that there is a high FT4 and T3 levels is sometimes undetected. T3, high T4 and T3 with undetectable TSH. RYU is also increased. Ibig sabihin, metabolically active ang thyroid gland. TAP is positive, TSI is also positive. Now, the patient with Graves' disease experience what we call ophthalmopathy. 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 Ano yan? Ayan, oh, ang laki ng mata. Naluwa yung mata. This is a condition, no? Other words is thyroid eye disorder or thyroid eye disease, no? Wherein the orbital tissue is swelling, no? and nagkakameron tayo ng injection of the conjunctiva. Sometimes double vision that can lead into corneal disease. Okay, aside from that, we have toxic adenoma, which is usually benign nodule no seen in the thyroid scan, and the TSH is decreased, the RIO is increased. Toxic, bakit parehas sila? Toxic multinodular goiter, okay, is also a condition wherein it affected, no, mataas din yung level ng ating T3 and of our T4. TSH, secreting tumor, is a condition wherein a benign pituitary tumor, TSH is usually normal to decrease and RIO is increased. Now, for non-hyperthyroidism, there is a painful thyroiditis, postpartum thyroiditis, exogenous hormone, and ectopic thyroid tissues. And then calcitonin, the other hormone produced by our thyroid gland, is responsible, no, for our calcium homeostasis. An increase in calcitonin is an indicative of autoimmune thyroid disorder, hypercalcemia, and neuroendocrine tumors. Like what I've said, situated in our thyroid gland is the parathyroid gland, which is responsible for calcium utilization, okay, near the hyoid bone in the neck or in the mediastinum. In most of the patients, there are four parathyroid gland, but sometimes it can be eight or sometimes two. And the only hormone secreted by the parathyroid gland is no other than our parathyroid hormone. Parathyroid hormone is important naman, no, in prevention of hypocalcemia, prevents calcium and phosphate, preserves rather, for bone reabsorption and for renal reabsorption of calcium. Again, the detailed discussion for calcium homeostasis will be discussed in the calcium homeostasis topic. We also have conditions affecting the parathyroid hormone and the parathyroid gland, which is the primary hyperparathyroidism, which is the most common cause of hypercalcemia. Laboratory results of a patient with primary hyperthyroidism includes increase in the parathyroid hormone, increased ionized calcium, hypocalciuria, and hypophosphatemia. Secondary hyperparathyroidism, on the other hand, is decreased serum calcium with diffuse hyperplasia in the four glands of the parathyroid gland. Okay? Laboratory results includes increased in the parathyroid hormone and decreased in ionized calcium. And lastly, we have our tertiary hyperparathyroidism, which comes with secondary hyperparathyroidism, wherein phosphate levels is normal to high. And lastly, we have our hypoparathyroidism, which is the main cause is accidental injury or due to autoimmune parathyroid destruction. And for the synthesis of our topic, remember guys that the synthesis of T4 and T3 occurs in the thyroid gland through a complex process regulated by the TSH produced by pituitary gland, particularly by our anterior pituitary gland. The TRH formed in the hypothalamus serves as the control for our TSH output and thus a negative feedback mechanism by T4 and T3. Iodine, an important element from the diet, is incorporated into tyrosine molecules, giving us the DIT and the MIT, no? Which are all important in the protein, which are part of the protein thyroglobulin and important in the production of our thyroid hormones. Remember, although it's still attached to the protein, two iodinated hormones or two iodinated tyrosine undergo a coupling reaction to form our T4. And one iodinated mono iodotyrosine and one diiodotyrosine will give us our T3. Remember that these thyroid hormones are released from the released, okay? And then the protein carrier enter into the circulation. It requires protein carrier, no, so that it will be delivered into its active or target tissue. Okay? The usual or the most common binding protein or transport protein is our thyroid binding globulin. Remember that the major effect of our thyroid hormone is to produce an overall increase in the metabolism rate. There are a wide variety of analytical techniques available for the quantification of our thyroid hormones. Okay? When measuring either T3 and T4, an initial separation setup must take place in the dissociation of TBG and of our T4. Okay? RIA or radioimmunoassay is predominant, and aside from that, other immunological assays or enzymatic immunological assays, including EIA and IRMA, can also be used. TSH is one of the useful parameter in assessing the function of our thyroid gland. There are conditions affecting the level of our thyroid hormones, such as such as your hypothyroidism and hyperthyroidism. In primary hypothyroidism, the problem is the thyroid itself, wherein T3 and T4 are less or decreased, wherein TSH is increased or sometimes normal. On the other hand, secondary hypothyroidism is a problem in the activity of our pituitary gland, and tertiary hypothyroidism is the problem in the hypothalamus. The laboratory results of secondary and tertiary hypothyroidism are almost similar. However, they differ in the level of the TRH. On the other hand, we have our hyperthyroidism wherein it is most commonly due to autoimmune disorder such as Graves' disease. Aside from blood tests, there are also other tests such as nuclear medicine, fine needle aspirate biopsy, and thyroid ultrasound. That is our thyroid function and the thyroid hormones. Thank you very much, and I hope you learn in this video. Maraming salamat po.